contamination with activated charcoal is trying to remove the drug, in essence, from the system before it can get absorbed. So remember, most things we don't absorb out of the stomach. So if we can intercept that drug prior to it moving into the small intestines, then we can, in a sense, inactivate it or tie it up so that it cannot get absorbed and cause any toxicity. So activated charcoal, there's a picture of it, and then it shows you the stomach and kind of gives you a sense of its effects there. I'll talk a little bit about what it is and what it does. So activated charcoal can be made from anything that will produce charcoal. So it can be from wood, coconut shells are a common source, coal is a common source. So they take the charcoal, they fire it up, and they burn it, incinerate it, and then they steam it to activate it. So activating it creates these crevices and pores that then can adhere or adsorb the drug. So people who are most likely to benefit from this are people who have had a recent ingestion, like within an hour or two, because we assume that the drug is still enough drug is in the stomach that we can access it with activated charcoal and inactivate it. So it has to be a fairly recent. There are lots of controversies about people who present later in using activated charcoal. It depends on what they have ingested. Many ingestions will be multiple drugs, especially if people were very intent on using a drug to end their life. They'll ingest many things, or they may ingest a drug like over the counter that has multiple drugs in it. So a lot of those times you'll get a drug that will slow down the gut. Okay? Or there will be such an amount of drug in the stomach that it just can't effectively move it on through the small intestine. So there are times when people will use activated charcoal even when it's been more than 1 or 2 hours. That is very controversial. Doesn't really hurt to give anybody activated charcoal except in larger doses. It can cause bowel obstructions, or if you're using it with sorbitol, you can get electrolyte disturbances from the results or the effects of sorbitol on the large intestines. Okay, so where do you encounter activated charcoal? Where can you think nowadays you see it? Pretty much everywhere. Where would you run into it? What?
Oh, like natural grocers?
Natural grocers, okay. And what would you use it for?
I've got mommy friends making it into gummy bears for stomach viruses.
What?
They're taking activated charcoal and they're making it into a form their kid will eat. And then if they get a stomach bug, they're giving it to them and they say that it helps cut down on
What possessed them?
everything because they're reasoning.
Okay, I don't know. Okay. Any of you have a bottle that has a filter in it that you use, a reusable?
Yeah.
Okay. So often we use activated filter or activated charcoal in filters. I had a coffee pot that the filter was full of activated charcoal, so I could change it out and have pure water. Our water reprocessing, purification systems have activated charcoal. So we use it quite a bit. We use it to extract chemicals. We can use it to extract smells. So activated charcoal is pretty good at doing that. So it's in common use, and we're just using it to our benefit in an overdose situation. Okay. So if you look at the activated charcoal, you see all these crevices and pores. They show you large pores here, smaller pores here. So they activate the charcoal we use in the emergency room with carbonyl groups and in different groups that will adhere a substance to it using electrostatic forces. Okay. So it doesn't absorb, it adsorbs. So what's the difference if you adsorb something versus absorbing it? If I stick a patch on my skin, do I absorb it or do I adsorb it?
Absorb.
I what? I absorb it. So when we do that, what does the drug have to do to get inside? Has to move through skin, has to move through tissue layers. So it diffuses through a barrier of some kind, and then it enters the bloodstream, right? Because that's usually how we dispatch drugs. And it solubilizes within the bloodstream so that we can carry it somewhere. That's absorption. Adsorbing means it sticks to. If a drug adsorbed to my skin, it's not going to go anywhere. It's just going to stay there. So that's what activated charcoal can do. It adsorbs. It holds that drug onto the surface of its pores and not pores, but in those crevices. Its absorption capacity is amazing. 1 pound of activated charcoal has the absorptive capacity of 125 acres. That's huge. So a usual dose in the emergency room is 50 grams. Okay. That is equivalent to 13.7 acres, or about the piece of land that we are about to move to, Dr. Brittany. When I think of that and I walk that land, that's in that small amount, that's how much absorption. That's why it is so effective. Okay. It doesn't absorb everything though. Salts, it doesn't tend to do very well. Alkaline material, it doesn't tend to do well. And it is a shame, it will not absorb alcohol. Okay. So it doesn't do everything. It does non-polar substances better than polar. So you won't find it indicated for all ingestions. Let's see. So if you look about under activated charcoal, the second bullet, the usual dose, we usually use it 1 time. There are times where we will do multiple doses, and we'll go over those. Those are limited. Usually 1 dose is all we use. In a maximum dose of 50 grams, that's the adult dose, or adolescent, older adolescent on up, that is a usual dose. You can give it to kids. There's a picture of a child who has probably more charcoal on him than inside of him. And give it to kids. Let's see, it should be withheld in those situations that are below. If they're non-toxic, don't give it to them. Don't put them in gummy bears and try to absorb viruses. Patients who present with a poison absorption is considered to be complete. So if it's many hours later or they're symptomatic, this will not help them. Poisons that aren't bound by activated charcoal that we mentioned, or who's had risk of complications unacceptably high. In opiate overdoses, we never use it because the risk of somnolence or the patient losing consciousness is too high. So that would be a time when we wouldn't use it. Let's see. I've gone through the indications. So let's look at contraindications. So a depressed mental state, risk of aspiration is too high. Depends on if the patient is going to be intubated or not. You don't withhold intubation in order to give activated charcoal. Late presentation of the poisoning, we talked about, increased risk and severity of aspiration. So hydrocarbon ingestions, we never want them to throw back up. So because they will injure the esophagus and can aspirate it into their lungs. So we wouldn't do it there. If you anticipate the need to use endoscopy for very caustic substances, they may want to look down and see how much of the gut has been damaged. I once saw a girl who came into the emergency room, drank an entire can of Drano. She just obliterated her GI tract. So in those circumstances, you wouldn't want to use a activated charcoal. We talked about toxins poorly absorbed, they're listed there for you. And if there's an intestinal obstruction, because these drugs can certainly form what we call bezoars, or big clumps that will not pass through the intestines, so that would be an absolute contraindication. And then if you have decreased peristalsis, it'd be a relative contraindication. Depends on the risk and the benefit for the patient. So dose. It's listed down here is that the activated charcoal to toxin ratio is 10 to 1. I have never seen anybody use that. It's theoretical. Most people are going to go by these doses that are listed below, and you should know those. Okay. So for kids, 1 year and under is 10 to 25 grams. 1 to 12, 25 to 50. So the closer they are to adolescents, you can go on up to the adult dose, 25 to 100. For adults, but usually 50 is the typical adult dose, and that's the one you should remember for adults. In terms of administration, it comes already available commercially. You can get it in a dry powder, which you can mix with water and have somebody swallow. It's very gritty. Think about chopping up coal and then swallowing it. That's about what it's like. So it's not very palatable. They do mix it with sorbitol, which is a sugar alcohol. A lot of your sugar-free gums have sorbitol in them. The biggest problem with them is that they cause a lot of GI distress because they act as an osmotic laxative. So they pull water into the gut, so people tend to get diarrhea and abdominal cramping from it. For that reason, if you use activated charcoal with sorbitol, it is only one time. Okay. So if you're in a situation where you would use multiple doses, then you would only use the sorbitol containing one time. The other times you would use just the plain powder mixed with water. With kids, it's recommended that you do not use the sorbitol containing activated charcoal because of the electrolyte disturbances you can get with kids. However, if it's the only thing that's available and the benefit to the child outweighs the risk, then use the sorbitol containing activated charcoal. Okay. Efficacy. If it is used within the time frame that very quickly after an ingestion, it's very effective. 50 to 75% of the drug can be inactivated or bound up. So that's good. You can get it down to where you're dealing with just super therapeutic dosing. Okay. So for a lot of drugs, that will be enough to keep them from dying or having significant complications. So a lot of factors can affect efficacy. So the amount that they ingest, the more they ingest, the less likely the activated charcoal can take up all of it. So that's one thing to consider. One is their food in the stomach. Are there drugs that they have taken that have slowed down the gut, like diphenhydramine or an anticholinergic? So those would affect. Adverse effects, aspiration is very low. It's often a side effect that providers worry about, but it's usually improper administration of that activated charcoal that causes the aspiration. So as long as it is administered correctly, aspiration risk is very, very low, and you don't give it to somebody who is likely to lose consciousness. The GI side effects are much more common. You can kind of anticipate those. Black stools, diarrhea because of the sorbitol, bowel obstruction if you're not using the sorbitol containing, nausea, vomiting, constipation. You'll see with some of the drugs that we're going to talk about, that's part of their toxicity, so that can kind of complicate the picture also. Multi-dose activated charcoal, you see it has a limited use. And the times when you may want to use it is if you have a drug that undergoes significant intrahepatic recycling. So the gut absorbs it, it goes to the liver, and the liver puts it back into the gut. That's intrahepatic recycling. Estrogens do that. That's one, they're a common drug for that. facilitating the drug moving from the body into the gut. So they call it a gut dialysis. So you create a gradient so that the drug will move from the blood into the gut. So that's a potential. And the other would be if you have people who have taken extended release or delayed release or long-acting products, often they're not going to be absorbed over, they're going to be absorbed over very long periods of time. So sometimes they'll use multiple doses of activated charcoal to bind those up because their toxicity is very prolonged. Hours and multiple hours over just a short, maybe 6 hours, and now you have a 24 to 48 hour problem. So here are the drugs. You'll see there's not very many of them. Carbamazepine, so one of the drugs for seizures, Dapsone, an anti-infective, phenobarbital, another drug for seizures. Quinine, we don't use hardly anymore at all. And then theophylline, again, another drug that's not used very often nowadays. So keep that in mind, very, very limited indications for using multiple dose. Side effects, contraindications are all the same. So how do you dose it if you're going to use multi-dose? There are several different recommendations. One is to give 12.5 grams every hour. The other is to give 50 grams every 4 hours or 25 every 2 hours. So there's really no consensus. It's dividing it up and giving it probably as patient can tolerate it, and then as depending on the symptoms the patient is having from the drugs as well. Again, don't use sorbitol multiple times. Side effects are the same. Complications, bowel obstruction becomes much more of a problem when you're using it in multiple doses. Did Scott talk about syrup of Ipecac? We don't use it anymore. We used to use it a lot. But it's not as effective. It's much more unpredictable about how much drug you can get out. Adverse effects are much higher, and it can delay much more effective treatment. So we don't recommend its use anymore. Also cathartic. So another thought is any way that you can decontaminate the gut, activated charcoal, lavage, or doing a lower gut decontamination by rapidly pushing the drug through the GI system has been another approach people have used. It's not recommended anymore. It's not very reliable. It has lots of side effects associated with it. So we don't recommend giving people things to make them go to the bathroom very quickly, like mag sulfate, sorbitol, mannitol, another sugar alcohol. Not recommended. Okay, questions about activated charcoal? Comments? Okay. Let's start with Thailand. So what did you learn about acetaminophen? Pardon? There's no prodrome. Okay. What do you mean by that?
Like they don't have symptoms until it's bad.
No, that's pretty true. So when they have lots of symptoms, it's already, their liver has already suffered a lot of insult. What else did you learn?
It's the metabolites that are toxic.
It's the metabolites, and it's one of the minor players. Gets to be a major player when we overdose. What else?
Essentially affects the liver.
Centrally affects, so you get central lobular necrosis. Why is that? Why is that the histologic picture?
That's where it's metabolized?
That's where it's metabolized. So that's where the P450 system, the 2E1, is the pathway. It concentrates there, and so you get the metabolite much increase in production. What else did you learn? Mucomyst, okay, glutathione. So mucomyst is what? Acetyl, cysteine. What's that have to do with glutathione?
Glutathione conjugates the metabolite and you use it all up.
Glutathione conjugates the toxic metabolite, cysteine is a precursor. There's three things that go together to make up glutathione. Cysteine is the rate limiting step. Okay. So we'll go back over that. But okay, that's good. What else? Anything else that you learned?
140 roll, right?
Yeah.
The 140? Okay, tell me that.
It's like 140 after 4 hours is toxic. Or if you go, yeah, 140
Milligrams per kilogram.
Then you give 140 loading dose and then half that for 17
That's good. That's a good way to remember it. We wait 4 hours. Why? Before we draw an acetaminophen level. Usually peak, so that's about the peak if they've taken an immediate release product. So it gives you a pretty good indication of toxicity. Okay, good. All right. Number one call to poison centers is due to acetaminophen overdoses. Broke down some stats. 56,000 ER visits a year due to Tylenol overdose. 2,600 hospitalizations, about 450 deaths a year due to liver failure. It's the reason for over half, or about half, of acute liver failures in this country is Tylenol overdose. Very significant because it's in everything. This says 600, it's probably more, it's probably a bit more than that, okay? I told you many modules ago, I don't like multiple dose products. I don't like multiple ingredient products, and this is one of the reasons. Is because people can take multiples and they get into trouble. The number one, people who have Tylenol overdoses, most of them have taken an opioid plus Tylenol product. Okay. So they may not realize that their Vicodin has Tylenol in it. And then something happens and they cough and cold this time of the year, then they go buy a ingredient product. I like single ingredient products. Okay? I never promote the combinations, and this is one of the reasons why. If you identify the overdose early, mortality is very low. The antidote is very good, and very unlikely that they'll suffer any liver damage or that they will die from the overdose. So the third one down there, once liver failure has developed, mortality is 28%. Of the people who survive, a third will need liver transplants. That's huge for taking over-the-counter product. So of the people who had unintentional overdoses, there it is, 63% were on a combination of an opioid and Tylenol. Let's see. So you can get acute poisonings with one-time dose or chronically. Here's what happened when I was a resident. I was on call with a team the night before. Person came in. No, I wasn't in the emergency room. It was in morning report the next day. Team is presenting who was on call, and they present a gentleman who had come in who had taken about 100 Darvocet N100s, which is no longer on the market. Darvocet was propoxyphene, an opioid, which had Tylenol in it, about 650 milligrams per tablet. He had taken 100 over about a week. So escalating pain, he escalated his dose, he took 100. He took 65 grams of Tylenol over about a week's period of time. Came in with belly pain. So as I'm listening to them, at the end of the report I said, well, what was the acetaminophen level? And the resident looked at me and he said, I don't have it back yet. And I thought, that's weird, because usually they'll turn those around pretty quickly. So he forgot. He forgot. So and I understand, in the mix of everything, it was, there was a lot to do for him. So because he had a delay in treatment, his liver enzymes got up to 10,000. But he survived. I was amazed. But it's, I think, mostly because it was a chronic ingestion. He had been on Darvocet for a long time. He had just continued to escalate the amount that he was using. So that's an example of a chronic ingestion versus a one-time. Management is gut decontamination. You can certainly use activated charcoal, but the antidote, which you all have already been introduced to, is N-acetylcysteine. So that's good that we have a specific antidote. When we get to the beta blockers and calcium channel blockers, we'll see there's not one. So we have to use all kinds of things to try and combat its pharmacologic effect. That's one thing to kind of keep in mind. When we go through the drugs, if you think about what the drugs do, you can often predict and remember what they're going to do in an overdose situation. Often, it's an extension of pharmacologic effect. In this case, it's not, because a minor problem that we never have to worry about becomes exaggerated when the drug is taken in large amounts. So kind of think about that as we're going through. This is not an example of that. This is where we've got a problem that doesn't exist in therapeutic doses that we see in overdose. So just a reminder, the dose for a child, thinking back to Module 2, is 10 to 15 milligrams per kilo per dose. For an adult, remember what the max dose we always talked about for an adult of Tylenol in a day?
4 grams.
4 grams. If they drink, what do? 3. So 3 to 4 grams of Tylenol a day or acetaminophen is an adult dose. Toxicity is likely when you get above 250 milligrams per kilo or 12 grams over a 24-hour period. Usually severe toxicity comes when you get up into the 350 per milligram per kilo at one time. One of the problems with Tylenol is it is rapidly absorbed out of the gut. So that's why when you talked about there's no prodrome, you can have hours where the patient doesn't feel great, but they don't feel terrible. They may not seek drug therapy. We talked about post-ingestion, 4 hours is about the peak. And on the, did you all go over the nomogram that you used, the REMAC, Matthew? Okay. So delays in getting to the peak are as if you had taken something, co-ingested something that slowed the gut down, could change that peak. Or if they took an extended release product. And there are quite a few of those on the market. Remember, serum concentrations of acetaminophen therapeutic are 10 to 20 mics per ml. So under, you all covered, this is on the next page if you want to look at it. So normally this drug is conjugated in the liver to make it more soluble and to be excreted by the kidneys. So the liver takes acetaminophen, it either puts a sulfate group on it or a glucuronide group on it, conjugates it, and it's soluble, very soluble, and the kidneys just get rid of it very quickly. That's 90% plus of the Tylenol you would take. A little bit of it, the kidneys can handle on its own, and they just get rid of that. That's about 2 or 3%. So you're down to about 5 to 8% of the drug that's left. That is what gets shunted through the P450 system. So it's some pathways you haven't seen before. The 2E1, not a very common pathway. I don't think we've run into any drugs that are metabolized through that. 1A2 is a minor pathway for most drugs, and then the 3A4 you know about because we talk about it quite a bit. So as long as it's, when it goes through that pathway, you produce that toxic metabolite, that NAPQI. Usually glutathione is hanging around, it conjugates with it, you get another soluble compound, kidneys can take care of it. But when you deplete the glutathione, and then when you use up, when you're down to about 20% that's left, that's when toxicity occurs. So that metabolite can interact with many of the intracellular workings of a liver cell and kill it off. It's very hard on the mitochondria of the liver, so that's where it first attacks. And it forms some complexes that are that are now being looked at as ways of markers of toxicity when you are way past, when you have an ingestion that is so far out that you no longer taking the liver enzyme, not the liver enzymes, the Tylenol level is helpful. So look for that to come about in the next couple of years. They're looking at these intracellular products that are the result of the toxin combination with the mitochondria as markers. It's not in there, that's just free. It's freebie. You can throw it out at your next cocktail party. Okay. All right. So clinical presentation. So you have acute and chronic. So with acute, like you've said, it's very quick. It progresses quickly. It's probably the most acutely and most aggressive form of liver destruction that we have with any other drug or any virus or bacteria. So acute and onset, ALT and ASTs are what we will watch in terms of when they start to rise, there is significant liver damage that is done. So liver damage can even be done before we see those rise, but it's when they start to rise that is really, the patient is in trouble. If you're also seeing a prothrombin time also go up, that's really bad because you've got a significant amount of the liver that is affected that you can't make coagulation factors. So that represents a lot of toxicity. Chronic Tylenol with an alcohol user and marked transaminases spells really bad, especially if they already have liver signs of liver toxicity like a coagulopathy or they're jaundiced already. Look for acute renal failure in those people. It's not something we think about. We see it with chronic acetaminophen use, but acutely we don't really think about it. But if you've got significant renal failure, very high transaminases, think kidney as well. So the initial manifestations are mild and nonspecific, nothing that would probably even drive somebody to the seek help. And there's about 4 stages. So did you all go through those? Did y'all talk about 4 stages? Okay, let's go through those. So in the first 24 hours, there are nonspecific symptoms: nausea, vomiting, sweating, pallor, lethargy, malaise. Some people are asymptomatic, depends on how much they ingested, or if you may have an extended release where they may not have symptoms till later. Lab studies, so if you looked at their ALT, AST probably would still be normal. In more significant ingestions, they will usually start to rise about 8 to 12 hours after ingestion. Stage 2 is the next 1 to 3 days, 24 to 72 hours. Here's where hepatotoxicity usually is evident. Nephrotoxicity is probably going to occur in very severe, or if you have somebody who already has underlying renal insufficiency. So your elderly would be folks who might be at more risk. Of those who develop liver injury, it's most of them will be in the 24 to 36 hour range where that will become. So they'll complain of right upper quadrant pain, liver will be enlarged, it'll be tender to palpation. And so all other signs, so PT, bilirubin, all of those are going to go up. Renal function abnormalities may be present as well. Stage 3, this is where, if people die, this is usually where they die. They usually die of multi-organ failure. So liver enzymes keep going up. It's severe. You can see 10,000. The person I told you about was over 10,000. PT is prolonged. Why would their blood sugar drop? Why would they get hypoglycemic? Say it again.
The destruction of the hepatocytes are going to release these sort of glycogen.
Okay, so you're destroying liver cells. So are these people eating? Probably not. So there's no sugar coming in from a diet. How do you sustain yourself? How are you all sustaining yourselves right now? Your liver is breaking down glycogen and releasing it as glucose. You destroy enough liver cells, you can't, there's no more glycogen, or there's not enough. So blood sugars can go down. Very good. Let's see. Lactic acidosis, total bilirubin goes up, it's mostly indirect. When you break it down, it's mostly indirect bilirubin. Talked about the renal failure, multi-system organ failure. So these are people who came in too late, never sought help, weren't administered antidotes, missed it. Stage 4, if they recover, then if they survive that, then they enter a recovery phase. This is usually after 4 days, and it's a long process. So it may take them several months for everything to come back to normal. However, the good news is that if they survive it, liver will usually return to normal and there is not a chronic dysfunction as a result. So that's good. Acute kidney injury, BUN, creatinine go up. They also will have hyaline casts, and you will, what you would see there would be an acute tubular necrosis. That also usually people will recover from, and kidney function will go back mostly to baseline within a month. Acetylcysteine doesn't help the kidneys, just the liver. Okay, so you looked at the nomogram, which is on page 8. So the importance is the time of post-ingestion. Don't draw the level before 4 hours. This is acetaminophen on the y-axis, and the treatment line is above that orange line. So you're going to plot it in here, and if they fall into that area, then you would start one of the acetylcysteine protocols. Did you talk about the 72-hour versus the 20-hour protocol? So this is going to tell you when to use that drug. If they have taken an extended release product, then this may not be as helpful. It may require that you do a second level in order to establish where if toxicity is present or not. So on page 9, you're going to use you're going to use activated charcoal if that's appropriate. There's no contraindications. The N-acetylcysteine is going to be based on what happens off of that nomogram. It also can go off of, if you don't have access to that, or if it is going to be delayed, you can go off of the suspected amount that's been ingested. If you draw a level and you don't know when they ingested it or how much, you can look at the level that they're at. This suggests that if they're above 10 micrograms per mil, you would be justified in treating them. If they have liver dysfunction and they've taken the Tylenol on top of that, so a person at higher risk for liver failure. So we talked about the mechanism of action. So you've got that down. If you go down to towards the end bottom there, you'll see that glutathione is synthesized from cysteine, glutamate, and glycine. And that cysteine is the rate-limiting factor. Cysteine is not orally absorbed, so that's why we give it as the N-acetylcysteine, because it can be absorbed orally. Readily absorbed, rapidly gets into cells, hydrolyzes the cysteine, and allows the liver then to make glutathione. Okay, so on next page 10, there's 2 protocols. These are FDA-approved protocols. One is PO, one is IV. So if someone could not take PO, you have an IV. They're time limited, that's the 72 hours in 20 hours. So you talked about the 140 rule. So with the oral, it's a load of 140 milligrams per kilo, and then it's 70 milligrams per kilo every 4 hours for a total of 17 doses. You should know that. Okay. Very effective if you use it early on. Anybody ever been around N-acetylcysteine or Mucomyst? What do you remember about it? It stinks. Oh, it stinks. It smells so bad. So sometimes it's hard to get a patient to drink it, and if they do, they often have nausea and vomiting. You can pre-treat them if it's very severe. If they throw it up pretty soon after you've given it, you need to repeat it so that they can have time to absorb it. IV is there. You don't have to know the IV doses, but I do want you to know the oral doses. So IV is 50 milligrams per kilo per hour, and then they slow it down after they've loaded it and infuse it over the remaining part of the 20 hours. So when would you use IV? Vomiting, contraindications to oral. A patient won't take the oral. Maybe they keep throwing it up, or they have liver failure that would require IV therapy. When I was training, we used the oral, so I'm not sure what predominates in ER. I'm assuming the oral does, less expensive than the IV, but from time standpoint, maybe they use the IV, I'm not sure. Adverse reactions, it produces a lot of allergic reactions, can produce anaphylactic, so there should be equipment around to resuscitate the person or treat that if that's the reaction. Fairly high, 10 to 20% is high. And the other side effects are GI, so treating them and preventing the nausea if it's getting in the way of them being treated is important. But what do you remember about ondansetron, Zofran? Prolonged QT, so because of that, we have a dose limit. So what's the dosing limit in a 24-hour period? 16 milligrams in it. So you can't give it before every dose, is my point. Duration of therapy, if it's a milder overdose and the person's all indications are that the liver is doing well and recovering, then they may not need the entire course, but usually we give the entire amount. Good prognosis if you get it in early enough. On the next page, page 11, there is a flow sheet for you. UpToDate does a really good job in giving summaries. This is there. I'm not going to test you off this specifically, but I think it's really good in terms of putting in one page what you need to do in a Tylenol overdose. Questions? This is an important one to know if you're going to be in the ER, and all of you will, because it's a required, right? Because you will see it. Okay, let's take a break. We'll start back at 4.